Hello, we're here at the 20th anniversary of the Conference on Retroviruses and Opportunistic Infections. My name is Jeff Taylor. I'm with the AIDS Treatment Activist Coalition, and I'm here with a distinguished panel to talk about HIV and aging. 30 years into the HIV epidemic, we have the luxury now of dealing with people who are growing old with HIV, and there's a lot to talk about. Sitting with us today is Dr. Peter Hunt from UCSF, Dr. Seema Desai from Rush University, Alan Landay also from Rush University, and Tim Horn from Treatment Action Group in New York. So thank you all for coming and joining us today. And look forward to a vigorous discussion. Tim, did you want to start out with a few questions?
Sure. An interesting conversation occurred during one of Monday's sessions on cardiovascular disease, in which Joe Iran from the University of North Carolina got up to ask a question, actually to make more of a comment, directed at the issue of premature aging. Which is the terminology that's been used frequently, as in the fact that we are seeing people living with HIV developing complications of aging at a younger age. Dr. Iran's comment, which actually resonated with me, is that we still shouldn't be calling this premature aging, as it's much more it's a much more complex issue, and actually that terminology actually sends the wrong message in terms of what in fact is going on. So I'm just wondering if you could comment on that.
Yeah, I totally agree with that comment. While people with HIV are at increased risk for a lot of diseases that we normally associate with the aging process, like cardiovascular disease, many cancers, osteoporosis, bone fractures, many of these things are increased in people with HIV. But not all things associated with aging are increased in HIV. Certain cancers, for example, prostate cancer as one example, commonly associated with increased age in people without HIV, but doesn't really appear to be increased in HIV. And there are many other examples like that. And so I think and ultimately I think we need to ask ourselves, why are we focusing on this? We're focusing on this to improve the health of people living with HIV. And in order to do that, we need to understand the mechanisms, the reasons why these things are increased. And instead of just calling it aging, it may or may not be the same thing that happens to people when they get older. And it may not be the same exact mechanisms that are driving it. And we need to understand those mechanisms to develop new therapies and interventions, so we know exactly what we need to pay attention to.
We also need to understand other contributing factors, and some of those are perhaps modifiable lifestyle factors, including smoking, diet, alcohol use. All these things may contribute to some of the inflammatory responses that increase the risks for the various comorbidities that Dr. Hunt just elaborated on. And I think this is a critical part of also looking at other co-infections that the HIV population has, including that of the hepatitis C virus and also cytomegaloviruses. Both of those may be contributory, and as Peter just said, the mechanisms that we see for the increased incidence of these diseases in HIV may be different than what we see in the normal aging population.
So in a way, I agree with the comment that was made at the session, but I do want to say that independent of what we call it, the phenomena is occurring where you see non-AIDS related comorbidities, as we call HANA comorbid conditions. And so more than what the term is used, we have to deal with the situation. And so I think, as Peter said, that it's important to elucidate the mechanisms that lead to these HANA comorbidities and try to intervene on those processes. I'm sure it's extremely complex immune system that we are dealing with. But nonetheless, I think that we have to show that the senescent immune system indeed leads to these conditions. And whether it is premature or not, there is a very strong evidence that these comorbidities do occur. Okay. And it is important that we deal with those comorbidities. Yes, we need to find a most correct terminology to it. But nonetheless, I think it's a ground situation where HIV-infected population is aging, and there are age-associated conditions. So I think it is important to elucidate the mechanism and then subsequently intervene.
Okay. I just wanted to just build upon something that Dr. Landay just talked about, which is the issue of inflammation. That we know that inflammation is the key underlying factor of these various complications that we're talking about here. Now, Sharon Lewin from Monash University gave a beautiful, very eloquent talk yesterday, really talking about the drivers of that inflammation, the factors that sort of exacerbate that inflammation, and of course, the consequences of that inflammation. Well, what she also talked about were really just a number of compounds that are being explored to actually remedy, to reverse, to halt, whatever, some of that underlying inflammation. Now, a lot of it looks very exciting, but we really don't have much data from clinical trials. So where do we go from here? Based on we have these compounds, we have these really interesting drugs that may work to help to undo some of that inflammation. Where do we go from here?
Yeah, so that's the million-dollar question. So the first step, I think, is trying to identify compounds that appear to affect the parts of the inflammatory process that in other studies we seem to predict getting sick, premature death, cardiovascular events, cancer, et cetera. And I think the field right now is using smaller pilot studies to see if some of those markers go down with things like statins, for example, the cholesterol medicines. And Grace McComsey has a really nice poster on her trial that she'll be presenting this afternoon, which shows that in a well-suppressed treated patient population, adding a statin drug actually lowers levels of immune activation, and so that I think is an important insight. And as we and then we need to ask whether the reduction is enough to likely be clinically beneficial. And that's another thing that we as a field, I don't think, have come to grips with yet. Exactly what level of reduction do we need to actually have a big enough effect on decreasing events that we can design a large clinical study looking at clinical endpoints, meaning, how many, does the drug prevent people from dying, getting a heart attack, getting cancer, getting all these other things. And there are a lot of details in there that such a trial would probably need to be at least a couple of thousand people followed for a long period of time, and would require a lot of resources. We're going to want to make sure that the candidate drug that we have, we think is likely going to have a big enough effect on multiple of these outcomes enough to invest in a study that size. And I think that's what the field is grappling with right now.
I think the other aspect, as Peter pointed out, and was a question asked of Sharon Lewin, is that we're treating the biomarker. And the question is that really the relevant outcome measure? I mean, we have, the ability to do easily quantitation of these inflammatory markers, IL-6 being one of the best, in work that Peter Hunt had presented from the SOCA study, and then also work presented here from Alan Tenorio and ACTG329 alert study showing the association of IL-6 and outcomes. I mean, that's great. That's really gives us puts us on the path. But at the end of the day, we need to say is, as we said, the endpoints, the clinical endpoints, and how do we measure those? Are there other functional measures beside our laboratory measures? And we're starting to think about that. Are we going to be able to use IMT, interval medial thickening, FMD, flow media dilatation, to measure the risk for cardiovascular disease? Are there other measures, or DEXA scans for bone disease, or neurocognitive, or scans for that? And how do we develop that? I mean, maybe one of the things we're trying to do in the field of HIV is take something out of our lessons with gerontology. What have the gerontologists done to study normal, healthy aging? Although, again, as we raise the question as well, is the same changes we see in the normal aging process what we're going to see, and can we use those same measures? But at least it gives us a window into what we may be able to look at in terms of functional outcomes that will go beyond just treating patients for a change in a biomarker.
So I think I agree with both the gentlemen, especially what Peter said about the endpoints. So you do need a clinical endpoint, and that you would have to power a study to a vast number of ends to come to a conclusion whether really the intervention works to reduce inflammation. Also to use a biomarker along with to identify whether these outcomes are associated with a particular biomarker such as D-dimer or IL-6. I think heart has improved immune activation, but inflammation persists, and these comorbid conditions are associated with inflammation. So I guess we do need to add adjunct strategies to dealing with inflammation and associated with age-related comorbidities.
Okay. I guess one thing is everybody wants to know what they can do now.
Yeah.
And I think that when we look at the statins, I mean obviously statins aren't side effect free. I mean they have their toxicity, so that we need to make sure that the benefit outweighs the risk, especially for inflammation. I mean I know that there's a drug that's approved currently for arthritis and for psoriasis, which will also have its own toxicity levels. But one drug that is also being explored is aspirin. And that we know in the HIV negative population, especially as they age, that aspirin is very much recommended to ward off cardiovascular disease, especially if you are at risk for that. So is aspirin something that people with HIV should be considering now to potentially reduce the risk of cardiovascular disease? Are there any problems with that?
Yes, that's a great question, and we're actually planning a study right now in the ACTG to see whether aspirin lowers a lot of these markers that we're interested in. But as to whether people should be using it while we wait for the scientific evidence, my own belief, and it's a belief not grounded in science, but my belief is that it probably is protective. But at this conference, we saw some observational data suggesting that the aspirin doesn't appear to be as protective in people with HIV as compared to people without HIV. Now, I think there were some methodologic issues with that study, so I don't think we can say for sure. I think ultimately it will require a clinical trial to prove that. But there are examples, like in diabetes, for example. We thought that's a clear population at risk for cardiovascular disease. Yet more recent studies of aspirin for primary prevention and of heart disease in diabetics it doesn't show much benefit, and they may be at higher risk for toxicity from the aspirin, meaning bleeding in the stomach and the like. And so even in a population where we thought for sure aspirin would be helpful, it may not be in some populations, and so it does need to be studied. And so you get down to now, how we, in the midst of this uncertainty, what do people do? And doctors have those conversations with their patients all the time. I do with my patients, and it's my feeling is that I think that aspirin is likely to be protective. And so if there's a question, I often lean towards recommending it. In the absence of evidence, but I tell my patients that we really don't know what the right answer is right now. This is just what I think right now, but we really need to do the studies. And so if we have a study open, I'll encourage my patients to participate to help others answer this question that we're wrestling with. So.
There is one large international study on aspirin called the ASPRI trial. It's enrolling 19,000 individuals between the U.S. and Australia, and I think they've enrolled about half. In the U.S., they're looking at more of an enrollment of minority subjects than in Australia. But at the end of the day, that's a huge study, and they do have clinical endpoints. And I think they're going to be looking at cardiovascular disease, neurocognitive outcome, and cancer, mostly related to GI-related cancers. So it will give us, perhaps using, again, randomized trial, low-dose aspirin, some hints. But it's a long-term study. It's a lot of people. And I think, as Peter said before, as we move to thinking about these same trials, even if we do one in the ACTG, it won't be a definitive study with the clinical endpoints that these larger studies are. It will use biomarker endpoints. So I think it really is up to the clinicians and making clinicians as educated as possible about all the pros and cons of using aspirin on a routine basis in our HIV population.
You mentioned neurocognitive decline, and certainly early on in the epidemic, neurocognitive problems were were huge, and as people age, they're beginning to notice it again, and I think there's a real question as to whether or not this is normal aging or whether HIV is associated with it. And what are your thoughts? Where is the research on this right now as the neurocognitive decline in HIV as people get older?
So initially in the epidemic, there used to be HIV-associated dementia. Now a milder form is more evident, and I think a lot of presentations at the conference were posters and presentations are made related to how monocytic activation is associated with neurocognitive deficits, and so I would think that some more research into this would be warranted before we come to a conclusive statement as to what is actually going on in the brain.
Let me ask, switching gears just a little bit, which is, the CDC presented some data here, taking a look at smoking, and certainly we're actually seeing a lot more data around the issues of cancer. And we saw yet another study here that basically showed that rates of KS, soon after treatment, HIV treatment is started, rates of KS drop, rates of lymphoma drop. But we do see over time, as we see this increase in the risk of these non-AIDS related cancers. And the one conclusion that always comes up is that we need to be doing more to screen people living with HIV for these cancers. The one thing I'm not very clear on, and I don't think we've seen too much of this, is what exactly does that mean? What should doctors be doing, and what should people living with HIV be asking for?
Yeah, it's a great question. So, and it gets a little bit back to your first question about, premature aging, which sort of suggests that things are happening at earlier ages. And there's a difference between that, people getting disease at earlier ages, and people just being at increased risk for them at similar ages. And so because for cancer screenings, take colon cancer screening. It's not a big one, but in terms of a cancer increased by HIV, but we have regular screening for most people at average risk. At age 50, you get your colonoscopy, right, or some other modality of testing. And the question is, should we be screening people earlier? For many of these diseases, we don't necessarily have data that people are getting them, a lot of people are getting them at much younger ages to warrant screening earlier. But the bulk of the problem is that, once you get to those older ages, over 50, you start, you're at much higher risk for these conditions than people without HIV. And so doctors just need to be more aware of that elevated risk and be more vigilant and at least make sure that recommended screening for people over the age of 50 is happening. We're not always very good. Busy office visit with lots of, if you've got 15 minutes to between you and your doctor, it's hard to get everything checked off the list, and then at the end of the list is screening for things, and sometimes we don't get to that, but it's really important that we do, and particularly in people with HIV who appear to be at increased risk.
I mean, one of the other things, I think I was at one of the meetings here before on Saturday, and we started talking about screening for anal HPV and anal cancer, and I think that's coming up more and more in the high-risk populations that in the HIV group, and something I think that, again, an awareness from the physician when you have a person in the HIV populations, this may be something more clinically relevant to look at. And I think, as Peter said, it's really being aware that this is a HIV infection is another contributing factor that can, perhaps drive through the processes we've talked about, inflammation being one of the major underlying processes that can contribute to these conditions. And I think that's the important part is, as you're reaching age 50, you see the physician, they're really aware of the screening for things they may not think about in their HIV negative population.
I'm glad you mentioned anal cancer because that's one that has dramatically increased in people with HIV, not just MSM, but women, and at all ages. It's not an age-related cancer, really. So I think it's really important for patients and their clinicians to be really aggressive about requesting anal paps, seeking out providers who do it because not everybody does. If they're appropriate candidates for getting vaccinated, the HPV vaccine can help protect them. So.
Oh, absolutely. And I've been talking to our adolescent medicine group in Chicago, and they're seeing it both in men and women, and young boys and girls, I guess, at those ages, and they're really seeing the increase, and I think that does become a major concern across all ages.
Yeah, the Adolescent Trials Group and the AMC, the AIDS Malignancy Consortium, have collaborated on the trial to look at just that question. So.
I guess I kind of want to revert back to the first part of my question, which is the issue of smoking. Which is, like I said, there's additional data here that's showing that about roughly 50% of people living with HIV are smokers, and that trend has not really abated so much. However, there are a number of individuals who are trying to stop, who see the importance of stop. So I'm just wondering if we can speak at all to the issue of smoking. I think that it was very interesting because there was one study that was presented again at the cardiovascular session that really just showed this, this trend that headed skyward in terms of cardiovascular risk. But then once you took smoking out of the equation, that risk dropped incredibly. And I know that we've seen that with others. So I'm just wondering if we can talk a little bit about, is smoking, is it playing a really profound role in a lot of these issues?
Yeah, so there's actually two issues there. One is that smoking is obviously a major risk factor for heart disease, and it's really important for doctors to talk to their patients. And smoking cessation programs, I do it all the time with my patients. But the second issue is whether HIV might actually accelerate the damage caused by smoking. And that's something that there's been some suggestions here or there that might be the case. So that's an area of active study. And so it may be even more important that people with HIV stop smoking than people without HIV. So all these things you really need to emphasize as physicians talking with their patients.
Yeah, I'd like to thank you all. This has been a really wonderful discussion, and we could obviously go on for hours and hours until we get much older ourselves. But thank you again for taking the time to
I
speak
can even
with
feel
us.
my telomeres.
Thank you.
Thank you again.
Thank you all.